Hi, my name is John Leonard from Weill Cornell Medicine and New York Presbyterian Hospital. Welcome to our recurring medical education video program for patients called REDLAMP, or Review of Emerging Data for Lymphoma Patients. I'm here today to speak to you about a new publication published in the Journal of Clinical Oncology earlier this year. And it is entitled Routine Imaging for Diffuse Large B-Cell Lymphoma in First Complete Remission Does Not Improve Post-Treatment Survival, a Danish-Swedish population-based study. So this is an interesting paper that follows on to a number of different studies that have looked at imaging in large cell lymphoma. As you may know, large cell lymphoma is a curable type of lymphoma that is typically treated with chemotherapy. The R-CHOP regimen is most commonly used, although there are a number of others. So when patients are in remission after R-CHOP therapy, a major question comes up as to how patients should be followed. Typically, people see the doctor on a regular basis, perhaps every 3 to 4 months for a couple of years, and they get laboratory work at regular intervals. So a question that comes up is whether or not patients should have routine scans. One would think that getting follow-up scans when one is in remission is a good thing because you might detect a relapse sooner. However, there are some downsides to scans. Those downsides include radiation exposure from multiple scans over time, the incidence of false positives, meaning that things may be found on a scan that could lead to unnecessary workup or unnecessary procedures that wouldn't perhaps in the end make a difference in patient outcome and might have some adverse effects. Certainly regular imaging also can cause stress and concern among the patients. It can be expensive. And so there are a number of reasons why regular imaging might not be of value or could in fact be counterproductive. So over time, many investigators have limited the use of follow-up scans. If a patient is feeling well with large cell lymphoma and they're in remission, one might argue that they can just be observed and monitored and only get a scan if there's some evidence that new abnormalities have emerged, the patient has a new symptom, a new finding on their physical examination, or laboratory abnormalities. And there have been a number of studies that have suggested that this may in fact be an appropriate or very reasonable approach. And so the current study looked at a population of patients from the Danish group and from Sweden that were treated with basically predominantly R-CHOP therapy from 2007 to 2012. And this was a group of patients that were between ages of 18 and 65. This might be a group where you would think would be a good group to aggressively pursue in follow-up and to look very carefully for remissions. So interestingly, the Swedish group and the Danish group were approached in a very different fashion. The typical follow-up in Sweden over this time was to basically monitor the patient every 3 to 4 months for several years and to get blood work at regular intervals. In this group, the Swedish group, imaging was only performed if there was a reason to do a scan, meaning that the patient had a symptom or a finding. The Danish group, in contrast, were managed in the same way, except they had regular scanning, usually every 6 months for 2 years with a CT scan. And so the question would be, did one patient population do better than another? Did the group that had regular scans live longer or do better? So this study had between 500 and 600 patients in each of the two groups, the Danish group and the Swedish group. The findings of this study basically were that the two groups were quite similar in their risk profiles. The important thing that I think came out of this was that the incidence of relapse, if a patient was in complete remission at the end of treatment, the incidence of relapse was quite low. And so this is certainly reassuring for patients. Depending on their risk profile, the incidence of relapse was between 6 and 20%. So across the board, relatively few patients, less than 20% across the board, had a relapse. So that should be reassuring to most patients that the chance of relapsing once they go into remission with large cell lymphoma is relatively low. The risk profiles of these two groups of patients were quite as expected, and they were quite similar across the two groups. And the most important finding of the study was that the group that had regular scans every 6 months for 2 years, was the predominant schedule, did not have a better outcome. They did not live longer, they did not do better. And so this suggests that basically doing routine scans in large cell lymphoma patients who are in remission and have no symptoms is of very little value. I think this is an important piece of information for patients. It builds on prior work, it builds on prior studies. It's probably the largest series around in the world of patients treated in these two fashions and compared head to head. And it really provides reassurance that patients who are in remission with large cell lymphoma should only get scans if there's a reason to do a scan. So what's the take-home message for a patient? I think the take-home message is that for patients in remission, particularly with large cell lymphoma, we shouldn't automatically get scans. There is not a basis to have patients on a regular scanning interval where they automatically get a scan every 6 months or every 4 months if they're doing well. The real question is, are you feeling well? Does the doctor find anything abnormal? Are there any hints that there's a relapse? And if there is a relapse or signs of a relapse, then that should be pursued. But if the patient is feeling fine, the doctor's finding no evidence of remission, the chance of relapse, the chance of having a relapse of large cell lymphoma is relatively low, and scans should not be routinely performed. These are complicated issues. People should talk about them with their doctor, but I think the important take-home message is, again, do a test, do a scan if there's a reason to do it, not because a schedule is indicating such, because the data for such schedules is really quite limited at this point. Thank you very much for joining us today. I hope this was useful, and please check back with us for additional REDLAMP videos in the future. Thank you.